Now I have the privilege and the opportunity to moderate this panel discussion around molecular testing in lung cancer. And we've already heard about this today, and you've probably been involved in several other discussions throughout the day on sort of related topics, whether it's on personalized medicine, molecular testing in general, genomics, big data analytics. I mean, all of these, I think, are sort of converging. And so with me are people who have actually been involved, either overseeing initiatives that ACCC was involved in, or actually participating in their hospitals through the process improvement and quality improvement steps of actually looking at how they're obtaining tissue, do they have enough tissue, and then once they get the tissue that they need, how do they ensure that the proper patients are undergoing the right kinds of molecular tests? So sort of with that brief introduction, what I would like to do is just have each person start by just sharing what is your role within your organization, and how does that role impact, what role do you play within sort of that lung testing process? And I'll start with you.
Well, I started as a lung nurse navigator in 2010 with our hospital. We opened a lung cancer institute, and at that point, we started the screening as well as the thoracic tumor board, and tried to develop a full program. When all of the information came out on molecular testing and we gained more information, I would say probably about 2 years ago, the group made a decision. Included in this is a lung cancer advisory that we formed, and that was formed probably at least 2 years before they actually opened the Lung Cancer Institute officially for planning purposes. And with the group and a full decision of everybody, we opted to go ahead and say that yes, we're going to do molecular testing on all adenocarcinomas. So, we have tried to make that a pretty consistent thing within our facility.
Okay.
I'm Kerry Presson, and at Wilshire Oncology, we've been part of many lung cancer clinical trials, and we've tried to prepare our institutions where we've been practicing to create the proper evaluation of lung cancer specimens, particularly the non-squamous specimens where we want to do additional testing with various mutations. And it's been variably received by different hospitals depending upon how sophisticated the pathologist is. I found the talk this morning on looking at establishing reflex testing to be very informative, because it will bring our pathologists a greater way along. I've also enjoyed the experience with the development of our learning labs to be able to share this with our pathologists and radiologists and pulmonary surgeons to try to make certain that they're on the same page with regard to getting adequate specimens, so we don't have to repeat biopsies. We know that the inevaluability rate is about 10%, sometimes as high as 20%. So trying to find value in those learning labs and to transmit that to all of our participating institutions is very important. Now that Wilshire Oncology has transitioned to become part of City of Hope, we know that our City of Hope pathology program does this very effectively. However, transmitting that same technological expertise into a community setting is something that remains a foremost challenge for us at the present time. But because of the learning labs at ACCC and the resources that we've been developing, I think this is going to be much more facilitated over the next 12 months, hopefully 2 months, but it'll probably be 12 months, to try to make certain that we're able to implement that. And as we do this, we have to remember also that this is not a completed program yet, because just as we know that we have many molecular targets for the drugs that we have currently, new drugs will be coming that have different molecular targets. Having a system in place now at each of our institutions where we can implement new tests that have to be done as soon as we have identified an active drug will become very important, not just for chemotherapeutic drugs, kinases, but also for immunotherapy as PD-1 and PD-L1 become more established. We know that these results have been very encouraging in non-small cell lung cancer. Part of the outgrowth of the genomic testing capabilities in any pathology department will be also the capabilities of identifying appropriate patients for subsequent immunotherapy programs as well. So it's a work in progress, and it's a challenge that each of us shares in our institutions, and by getting the best practices together, we'll be able to implement better programs.
Great. Dr. Wagman?
Yeah, Larry Wagman, and my disclosure is that I'm not a thoracic surgical oncologist. My expertise is mostly in the abdomen. So I stand back from this in my role as the executive medical director responsible for programmatic development at the Center for Cancer Prevention and Treatment at St. Joseph's in Orange, to bring together the experts, the disease experts and the care delivery experts, pathology, radiology, interventional radiology, and to get them to look at this question. We were very fortunate as part of a larger health system, the St. Joseph Health System, primarily in California and also in Lubbock, Texas, to have a conversation between the CMO at St. Joseph of Orange and a large pharma, Pfizer specifically, who's sponsoring. And I think that's the benefit of relationships between health systems and pharma, to talk about how we could look at this particular issue and see how it was actually working. So we have a fairly sophisticated thoracic oncology program, has over 30 members, full spectrum, including navigation. And so we had that infrastructure there already, if you will. We were an NCCCP site, so we had a lot of experience working with a variety of different populations. And the interaction with Pfizer and our hospital gave us an opportunity to do a lean methodology look at the way we were performing, get great input from all the shareholders and the stakeholders in the process, and see just all the places where things could go wrong along the way, look at the specific areas where they could be improved, and then create for ourselves an ideal process and then a set of parameters to look at and to start to measure to see if we were making progress.
Great, thank you for that introduction. And I think what's interesting hearing from the various presenters are the fact that, for instance, in lean methodologies, there's that recognition and acknowledgement that there's always going to be room for improvement. And that whole sort of culture of adopting and embracing process improvement, quality improvement, I think different organizations are at different places along that spectrum. And can you just share with us, what was it like to get the clinicians, the physicians, nurses, and other members of the healthcare team to embrace something like lean and to recognize that there is room for improvement here, because we're not talking about a patient safety issue or the fact that there was a medical error and now we have to do a root cause analysis to fix things. What was that like to just get everyone on board?
So you may find this remarkable, but because people sense that there'll be improvement and they know they're part of the improvement process, it was easy to get people engaged. I think what you find out is that if you embrace any given methodology, methodology is by nature generic. And when you start to interact with individuals, the information that you gain is often anecdotal. So probably one of the biggest things you have to do initially is you have to accumulate the anecdotal experience into put it together into a bowl. So now you're dealing with more general concepts that can be placed into it. So I was very impressed with the engagement of all levels. And this goes from the pathology department, tumor accession pathology assistants, all the way across to our front door financial people who would find out what insurance the patient had and just see how all that fit together. So I like that. I think you pick a methodology. There's probably not a right, I know there's not a right one or a wrong one, but you say you're going to stick with it. Realize you're only going to make minor modifications as you go along so that you can still use the power of the methodology, which has been derived as the basis, and then throw your data in and see how it plays.
Great. And Wendy, I'd love to hear your perspective too, because your center participated in the lung learning labs. And tell us about from the standpoint of leadership and engagement and sort of people championing this initiative to convince everyone of the importance and how to get people on board?
Well, when I first started, I found this study, with the ACCC, and I thought, well, this is something that we can participate in. Our hospital, it would work for us. So I first took it to our lead pathologist, and I asked him what he thought. And his response was, we'd like to think that all of our algorithms that we have in place are perfect, but most of them aren't. And, it would be a good thing to go in and really look where we are and see if we are perfect or what improvements we need. Obviously, none of us are perfect. And, the goal, so I started there, and then we proceeded with the Lung Cancer Institute Advisory Committee and got all the physicians together, and I presented it to them, and they were very much on board immediately. We have a very supportive group. All of the physicians on our committee and that are involved with our lung patients are really advocates for, good outcomes and quality patient care. So they were on board immediately. And as far as, when we had to plan for the lab, the learning lab, I thought that was going to be a little more challenging, because you wanted everybody there, and I thought, oh boy. I was very pleased, and you were there. We had excellent attendance. Many of the physicians could not attend the whole entire time, but all of them made a really good effort to be there part of the time, and they were very much engaged, and they've been excited to hear, what the outcome was as far as what we found and, some of the things we can do to improve.
Sure. So now, Dr. Presson, I know that you served on the advisory committee for the Learning Labs, and obviously, your leadership and your insights was very, very helpful for the entire initiative. What kind of suggestions or tips would you have for the people in the audience if they are trying to organize a process improvement project or an initiative, and they're having a difficult time getting that physician engagement or alignment? What can organizations do? What can leaders and administrators do? What can other clinicians do?
We're in a community that has a wide range of oncologists, wide range of pulmonologists, with multiple institutions with different pathologists involved. I think it requires a leader with vision to say, we have a lung cancer issue. We have smokers and non-smokers who are developing lung cancer, and it's one of the most common cancers in our institution. So it can start with tumor registry identifying the nature of the problem with lung cancer diagnosis, staging, et cetera. Integrating some of the screening methodologies, and also not just screening, but also appropriate early CT evaluations of minor symptoms in patients with lung cancer. It clearly involves engaging all of the different oncologists, whether they're from small practices or large practices, to get together and say, this is what the information is that we're going to need to adequately manage these patients. So by screening, perhaps getting some downstaging of patients, by getting the oncologists together and creating the need that can be presented to the pathologist to be able to say to them, we have to have the methodologies in place. And you don't have to reinvent these types of process improvement studies because the ACCC through the Learning Labs has already demonstrated how this can be rapidly initiated. Getting the pathologists involved, getting the surgeons, pulmonologists, and radiologists involved to know the adequacy of specimens that must be sent to the laboratory so that we don't have to rebiopsy and rebiopsy in order to get a therapeutic infrastructure necessary to make the appropriate clinical decisions for management. All this can be done very effectively, but it does require an inspired leader. Now that leader is often a medical oncologist, can often be an administrator, a navigator in a program, and navigators are very good at bringing all the people together as well. So looking at who are the resource people within your institution who can be at the forefront of this type of effort is very, very important. And I like the idea of having a very small team, probably a very active pathologist with a very active nurse navigator, together with a very active medical oncologist, to help to carry the banner forward of improving the process on a day-by-day basis. Doesn't have to be reinvented locally, but you do need those leaders to incorporate all of the programmatic activity that's taken place outside the institution to be able to be integrated within it very rapidly. So start with that core leadership.
So you mentioned leadership, you mentioned vision. I guess one of the big challenges is just getting people into the room, and especially in a topic like lung cancer, where you've got a multidisciplinary team, you've got pulmonologists, surgeons, radiologists, pathologists, medical oncologists, and they all have busy schedules. They have meetings on different days or times of the week. What is that sort of magic formula of coordinating and getting people into the room on a given day at a given time? You know, Wendy, what did you find that worked best in your organization?
Well, I know when we started the thoracic panel at the same time, and that's a multidisciplinary, and we have all of those disciplines that attend, and we do that twice a month. And initially, when it started out, it was a push. You know, part of it was getting them to just think that way. And I know part of it, too, was the medical oncologists and the radiation oncologists were very familiar with tumor boards and the benefits and you know, the positive outcomes for patients. The pulmonologists and the thoracic surgeons, it was kind of foreign to them. So the challenge was getting them on board, and it was just constantly going and reminding them, you know, we have it, we have new patients, we have new cases. And, you know, for the first year, I probably was the one initiating the cases and just telling them to show up kind of thing, and they did. But after a year, they really took off, and I don't think we have one now when, you know, at the beginning, it would be the physicians that were primarily presenting cases that would show. Now they're all there, whether they have cases or not, religiously.
Yeah, so it sounds like having patients and actual decisions that need to be made about patient care and just treatment decisions, having everyone, that's certainly one way of engaging them.
They really, really realized, you know, after a year of this and recognizing and really, you know, and I really pointed out examples of cases where had we not presented and discussed fully, you know, what would have fallen through the cracks. Mm-hmm. And they started recognizing that this was very valuable, you know, across the board. And plus, they got real engaged with each other on discussing such things as molecular testing and treatment.
Yeah. And Dr. Wagman, at your center, when you launched into this lean study, in terms of just getting people there, I mean, not every physician is necessarily familiar with lean methodologies, but I mean, was it a challenge? Was it fairly easy?
So no, I think it's really, this is the contrast. So we were having no problem at all with at our Thoracic Oncology Cancer Conference, held once a week on Monday, attended by 35 to 40 people, full spectrum of expertise, discussing the appropriateness of molecular testing, looking at NCCN guidelines, which is the way we do. Every one of our conferences has 8 points, and one of the points is NCCN guidelines. We bring up the guidelines, stage and disease specific. So we had no problem at all with the one-on-one. What we had the opportunity to do, though, was to step back and say, how do we make this a process that, okay, we'll pick lung cancer as the place to start, but how will we take this and make a generic approach for the biomarkers we know we have now and the biomarkers for the future? And that was really where the lean methodology came in. So the pairing of Pfizer expertise and the expertise internally gave us the opportunity to look at this in a much bigger way. And to be honest, if I was only charged to do this for one disease and one stage, I would have said, you know, it's really not worth my time because they're already talking about it. To me, the real benefit of this was to say, okay, now we have the model. You see how it works here. It's going to be a little different. The chaos points are going to be different in the lean methodology if you use breast cancer in second recurrence or whatever you want to pick, hepatocellular carcinoma. But now we have something that we can take to our GI group, we can take to our breast group, and we can say, okay, how do you all want to make this work for you too.
Right, operationalizing a process ultimately at the end of the day,
Right.
you can translate that into so many different areas. And when you,
Can I just add a couple more things? At the same time, we were able to leverage what our cancer committee does, so our medical staff cancer committee, giving us a reflex testing push, so that if we did find something valuable here, then we could go directly, having those people involved also, and say, okay, now make this a medical staff process, dictate this, and make sure that this gets done. And in addition, we're also developing relationships with both pharma for drug availability to our patients and with genomic testing. So we were showing everybody within our cancer center how we could take this from being a valuable question to analyze here, but how it would be beneficial to them, their patients, their disease of interest, their financial evaluation, et cetera.
great. And Wendy, tell us about some of the improvements that you all identified and implemented at your center as you went through this whole learning lab process.
Well, much of them we are still in the process of working on, but one of the things that we picked up on that we want to analyze further is we recognize that stage 4, out of the patients that we found that we did not do molecular testing on for whatever reason, were primarily stage 4. But we really don't know the true reasons. We're going back and trying to pull and find out, was it because they were going to hospice, or, were they just not going to have treatment? We're not sure what the reason is for that, so we do want to look at that. Some of the barriers with that we're finding is there's not enough documentation in there. And if there is documentation, it's fragmented because we work with primary or private practices. So if it's, something in the MedOnc records, we've got to go back and kind of track everything and pull it together. So we're not finding documentation in one place. So I've been working with pathology, and that may be an area where we end up fine-tuning that more in our system versus outside of the hospital system. Another thing that we're looking at is a big issue that we have found is not always having enough tissue. And they don't want to go back and, rebiopsy for that purpose if we can help it. So one of our pulmonologists has taken the lead and is scheduling to get with Mayo Clinic locally. And we're going to go, and they apparently have a very good record there. He's worked there, and they have a very systematic approach, and they're willing to let us come. And we're taking a team over there when they get it scheduled and just kind of watch their process with the EBUS. And what their process is for tissue collection. So that's another thing that we're looking at.
Great. And Dr. Presson, I know that your practice was recently acquired by City of Hope. You're going through this transition. How do they communicate things like standard processes, procedures around molecular testing, and how has that been communicated to the oncologists in your group?
Well, I've been with City of Hope for 18 days, so it may be a little premature to be absolutely certain. However, City of Hope has said, yes, we will make our expertise available. The pathologists have always, in the community institutions, relied on review of their findings by a university if there's any question about what's happening. They're very anxious to do all of the genomic testing as locally as they can, and City of Hope is also anxious to have that done as well. Also, the thoracic tumor boards at City of Hope will be online virtually in our various community hospitals, so that the patients in the community will be able to be presented at the thoracic tumor board from the parent institution in Duarte at City of Hope itself. But there's an elephant in the room. The elephant in the room is payers, because these tests need to be paid for. And we have a great reluctance of the pathologists to routinely do the type of testing without getting authorization from the insurers. So in addition to having passionate people who will take this challenge forward in terms of improving the process using lean methodology, we have to at the same time circle around and talk to the payers and tell them the importance of paying for this genomic evaluation to guide appropriate therapy. With appropriate therapy, patient rehospitalization, patient control of disease, patient excessive use of resources because of disease progression. Those problems can be minimized if there's appropriate genomic evaluation initially. But that won't happen unless we have the oncologists, the surgeons, the radiation oncologists, the pathologists going to the insurers at the same time that they're developing their in-house methodology, go to the insurers and make certain that they are fully engaged in the process of paying for these evaluations, which are part and parcel of NCCN guidelines. Sometimes insurers say, well, maybe we don't have to do all of that. But I think that's very short-sighted, especially as we are entering into an age where patients expect it, doctors want to do it, pathologists want to do it, and insurers must pay for what's adequate treatment and evaluation for that treatment. So we can't leave the payers out of this, especially within Southern California, as we have very heavily managed type of systems. So your initial question was, well, what's City of Hope going to do versus these community practices? And I can tell you that at tertiary care institutions, they very often do not have any problems getting authorization for any type of testing that they want. But once the very same people paid for by the same institution are out in the community, it's a different kind of payment structure. So we have to pay attention to the elephant, the payers, to make certain that they're fully engaged in the process of improving evaluation and treatment of lung cancer patients.
Sounds like, I mean, just having that negotiating power and even just being able to manipulate and understand the dynamics of the payment system, the reimbursement models, because it's like you mentioned, patients are expecting it, and in many cases, patients are asking their doctors, doctor, if I'm going to have this molecular testing performed, what's it going to cost me, or will my insurance cover it? So I think there's an increasing level for all clinicians to understand what's happening and how the reimbursement is being done. One question that I'd like to ask, if we could sort of rewind and go back in time, and as you look back on your journey, what's happened at your institution, what you've observed that has happened potentially perhaps at other institutions that have participated in this whole quality improvement and process improvement pathway, what could have been done differently? What could have been done better? Because after all, process improvement is continuous, and we need to always be looking and thinking about what we can do next, or what can we do that might be an incremental improvement or potentially a much bigger improvement. So Dr. Wagman, as you think back about the lean journey, and I realize that you're not over, the journey is not finished, but as you think back at the last 12, 16 months or so, what do you think are some of the things that could have been done differently that might have led to a better outcome?
I'm not sure if this is dodging the question, but I think many of these things, you're not going to look back and see. Occasionally you'll look back and see, oh my gosh, if I had only at some point. But I think these things are fairly tedious, and they require a lot of back and forth. It's a long volley before the point ends, each of the individual points. And because of that, I think maybe something that would have been trying to do incorrectly would have been to rush the process, not find out who was going to be the champion, not really understanding what was working and not working from the beginning. So for me, this lean methodology has been, and just the process of doing it, has been the most valuable part. And I would say that the importance is to keep it going. If I look back 6 months from now and find out that we stopped and didn't continue to explore the opportunities, then I would say that's something I should have done differently, or we should have done differently.
Okay. Dr. Presson, in terms of your role as a member of the advisory committee over the learning labs, I mean, are there things that you think we could have done differently that might have been better?
No, I think the obstacles that we face are institutional obstacles. Where we see problems are when the hospitals, the payers, whether they're IPAs or large PPOs or ACOs or HMOs, that the payers, the institution, and the clinicians are not in sync. the responsibility for having them in sync is the cancer committee or administrators within the institution who see the absolute necessity for having everyone on the same page. You can't have a great freestanding oncology program and not have very good in-hospital supportive programs as well. So in lung cancer, in particular, having integration of these programs is the most important thing. And if I look back 12 to 24 months, I say, isn't it silly that we've been focusing on the Affordable Care Act and focusing on contracts with insurers when we should have at the same time been integrating our program more effectively and bringing in all the oncologists and all the surgical oncologists and any outside institutions whose expertise we may be relying on. So making certain that that program is well coordinated is important, despite the fact that different people may find themselves as, quote, competitors with each other. In the long run, they have to be working together as a team.
So physician engagement, physician alignment, I mean, these seem to be themes that we just keep hearing over and over, especially around process improvement.
Physician alignment with administration, with payers. The payers have to be incorporated within this as well.
Sure.
At a very key time. And I think when that happens, you have the ability to apply lean methodologies. You have the ability to apply the learning lab methodologies, and you have the ability to incorporate what ACCC has been able to make available by its integration of administrators, vendors, pharmacy, and payers, and physicians, nurses, navigators, pharmacists, all within the same organization. Learning from ACCC makes it easier to solve these problems more expeditiously at a local level. So continue to be part of ACCC, but use ACCC. Use them effectively. Don't go home and just say, oh, it was a good meeting, and besides, I got to go to San Diego. Go back home and really think about, how can I use some of these people whose expertise I've heard about to help me solve my problems at home and get started on that process.
Sure. Wendy, any thoughts?
Well, I know that I very much appreciate that we've had the opportunity with ACCC to do this study and to be a participant, because it's opened our eyes, on a lot of, things that we can improve on. And I think it's changed our thinking on how we'll think further, as we grow our program and continue, and I think being able to improve patient outcomes, that's the ultimate goal. And I really appreciate that we've been a big part of this.
Yeah. Well, I think, like you mentioned, Dr. Presson, the discussions about best practices and identifying opportunities for improvement doesn't have to just end here in San Diego for this year. ACCC has a number of online resources and forums where I know that a lot of ideas are shared. Participating in the learning labs, I mean, we went to 8 different centers around the country, and we'll be sharing these things in an upcoming journal article as well. But I think one of the most valuable aspects of that was to share what was happening in one part of the country with folks in another part of the country, and sort of just that lessons learned and some crowdsourcing, if you will, but allowing people in the community to understand that when you've got certain dynamics and variables, and you can learn from your peers and your colleagues. And so I guess with that, we're pretty much out of time. I wasn't sure if we want to thank you all for your participation, and we hope that for everyone else that this is an opportunity where you can follow up with questions as well as connect with us online. So thank you very much.